Hey guys, I want to do a quick video summary of our discussions that were sort of from this weekend and also from last week when we talked about cervical radiculopathy. I think everybody had a pretty good idea of how they might go about examining this patient and starting a treatment program. And I think one of the things we talked about with radic is early on with our examination, we might leave out some of those more impairment-based exam things such as flexibility or motor control or endurance or strength beyond just a simple neurological screen, because early in the course of care, that's really not going to be our priority with this patient. The priority is going to be more getting their symptoms under control, trying to do things that will centralize their symptoms. Then as that patients are calming down or the symptoms are becoming more stable, less irritable, then we might start to look at things like deep neck flexor, cervical endurance, scapular muscles, maybe flexibility if that's still an issue, as that patient's symptoms have settled down. So think about it. For most of our patients coming in an acute stage, the stage 1 treatments are really going to be symptom management. As we progress into maybe a stage 2 treatment, if we're thinking about like a treatment-based classification, that's where we're going to progress more into those strength, endurance, flexibility types of things. So just kind of keep that in mind. It's a very simple concept that I think will help you to focus your exam and early treatment early on, and then remember that you don't have to examine everything day one. Plan that out for a couple of weeks down the road or whenever you think it's going to be appropriate to add in some of those things. And then you might even find that you don't need to do them, or you possibly don't need to do them. And then we talked about a variety of different treatment options this weekend and on the discussion board for helping to settle those acute symptoms in someone with a cervical radic, traction, lateral glides, opening techniques, potentially closing techniques if they tolerate those better, thoracic spine, MOBs or MANIPs. So I think we have a variety of good treatment options at our disposal. And then going into the educational piece, I think that article that describes how those symptoms come about from both peripheral and central sensitization, how you'll start to have symptoms outside of the dermatomal or sort of myotomal pattern, can be really helpful to describe to a patient and help to normalize it, or it makes sense to them so they're less fearful of their pain and disability. One thing that came up too would be, would this patient benefit from taking a non-steroidal anti-inflammatory? If we think that cervical radiculopathy acutely is an inflammatory thing, as long as that patient tolerates it from a GI standpoint, that's probably not a bad thing for them to do to help them, particularly with sleeping at night. Most patients that take an NSAID, they don't tend to take it around the clock. Early on, if you're trying to control inflammation, it's recommended that you take it, if you're taking like ibuprofen 3 times a day, naproxen is usually a couple times a day. So taking it as prescribed rather than sort of PRN, at least early on if we're trying to get an anti-inflammatory response. However, we do have to monitor for GI symptoms. So that's kind of pretty much everything I wanted to talk about. Like I said, we're working on making our history, exam, and treatment more focused based on our hypothesis, based on the goals at hand, and not throwing everything at them on day one just because we feel we need to be comprehensive with our assessment and treatment. So I hope you guys enjoyed the weekend and had a good week. This week we're going to talk about a case with TMD and headache, which we talked about on the second day over the weekend, so I'll be interested to see what you guys say about this case.